Welcome to Module 7. This module will focus on measures of use. For those of you that were in health systems, this is probably going to be just a refresh. For those of you that are working in a healthcare facility doing administrative tasks, this is probably going to be at what you do day in and day out every day. But for those of you that don't work in an inpatient facility and have not been in health systems, hopefully this will kind of get you up to speed with what to expect for our certificate of need process and how we think about measures of use for health services within our county. There are two main ways that we'll be looking at utilization. The first is our discharge rate. So this is simply discharges per 1,000 individuals. This is exactly how our Sparks data set is set up. Every row indicates a discharge. We also, though, are going to be really interested in something called a patient day rate. So patient day rate not only takes into account how many patients came to our hospital and were eventually discharged, but how long did they stay? This is an indication of two things. This is a proxy for severity of illness, so basically how sick was the patient, because sicker patients will obviously stay longer. But it's also an indication of operationally how we're running our facility. How are we doing with bed turnover? So once a patient is discharged and a new patient comes in, how long does that take? Are we discharge planning early in the process so that we can get the patient all of the services they need in a timely manner so that when they are feeling better and ready to go, we can send them home? So again, patient day rate is going to be really important for us, and it's going to be the main way that we do our projections for our final bed need forecasts. Again, that is a proxy for two main things: severity of illness and our operational capacity or abilities within the facility. Days of care, length of stay, which is the acronym LOS there, is going to be really important. That is basically how we're calculating our patient days. We're looking at the total length of stay for everybody that came to our facility. That is going to give us total patient days for the entire year. And based on what we know about those total patient days, we can do a lot in terms of strategic planning for the future. When we think about utilization, we know that utilization is higher among the elderly, our older age cohorts. So in our data set, we're going to be doing our analysis by 65 to 75, 75 to 85, and 85 and above. We know that as you get older, utilization increases. So those discharge rates and those patient day rates are going to be higher for those age cohorts. This is also why using the Cornell PAD projections is so important, because when we can visually see and when we can incorporate the increases in these elderly populations 5-10 years out, that gives us a really good idea of what to expect for our inpatient utilization. We know that children under 1 year of age are going to have higher utilization. Of course, if they're likely born in one of our obstetric wards. Women, for the same reason. We also know that people of lower socioeconomic status and Medicare and Medicaid beneficiaries typically have higher utilization rates. This is why in our analysis, we'll also be looking at the type of insurer for each of the patients that's coming into our facility. And that gives us a good idea, because if we know that we have higher Medicare and Medicaid rates, we are also probably going to see that we have higher discharge and patient day rates as well. Knowing that information about the people that we serve is really important, again, because it helps us strategically plan. A little bit more about average length of stay. So if anybody has ever worked in an inpatient facility, you know that this is constantly a topic of conversation. Well, I think we've kind of gotten to, we've capped out and plateaued at a pretty good place for most facilities. There are still some opportunities for improvement, but there's always this conversation where on one side of the camp, you've got, we know we need to reduce length of stay to increase our overall capacity, because if you can shorten the stay of a patient, that's by, let's just say, 1 day, that's 1 day that you have available for another patient to move into that bed. So that is a really, I don't want to say an easy way to increase capacity. That is a way to create capacity, but actually meaningfully reducing length of stay is much more difficult. So the other side of the camp states that if we push too hard on reducing length of stay, we might see the unintended consequence of increases in readmission rates. So in other words, we're discharging somebody before they're ready, and we're going to see that patient turn right back around and be in our emergency room in a couple of weeks because they weren't ready to leave. So there's a real balance there in looking at reducing length of stay. Again, we know that the biggest contributor to length of stay is severity of illness, but it's also basically our ability to operationally do what needs to be done. This is why we see that our length of stay is generally higher in federal hospitals. We know the VA has had a lot of issues in the past. They've gotten a lot of negative press about their length of stay. Again, and this basically boils down to operationally how are things being run in the institution. Private, nonprofit, and for-profit hospitals generally have the same length of stay. So I want to focus on these two graphs on the bottom. So the one on the left, and this only goes to 2006, and I apologize for that. But if we look at length of stay over time, we know that in the late 80s, average length of stay at any hospital was up over 11, 12 days. It has steadily declined over time. And we know that right now, this only goes to 2006, and we can see that there our length of stay was around 5 days. It's even less than that now, but not a lot less. I think for most hospitals, they're kind of in the 3 to 4, sometimes still a 5-day range, but we're still kind of steadily, we've plateaued there, I think bottomed out in a pretty comfortable place. That doesn't mean though that length of stay is not still a topic of conversation. It is, again, really important to the financial viability and the operations of the hospital. So on the bottom right, you'll see a graph for a facility that I worked with downstate, and we had an initiative. It was a strategic priority for the organization to reduce length of stay. They felt like theirs was still too high, and they needed that extra capacity, but didn't have the capital resources to be able to build out new beds. So as we were looking at, and as we had kind of this big push, and we were doing a lot of work on discharge planning and admission with multidisciplinary teams, we were seeing some great movement in length of stay. We were doing the analysis on an individual ward or floor level, and over time, right, we were seeing gains or improvements in length of stay, but then the fall came and they started to creep back up. And some executives were very concerned, like, what all this work that we've been doing, what's the point of it? Our length of stay is going back up. When we looked at historical data, we can see, and we know that if we do this analysis by month, that our length of stay is higher in our winter months for two main reasons. One, again, your high utilizers, your elderly population are going to have respiratory illnesses more often in our winter months. The second reason is for this facility that typically has a very high proportion of patients that have Medicare and Medicaid benefits, lower socioeconomic status. Many of the patients didn't have a safe place to go upon discharge. And as a result, the more we kind of talked with and uncovered with our frontline clinicians, with our nurses and physicians and PAs, that there were a number of cases where they weren't discharging a patient because they were concerned about what was going to happen to that patient, whether they were homeless or whether they didn't have a safe place to go to after they were leaving. So again, if we think about lower socioeconomic status, somebody going back to potentially an apartment that is not heated is a major concern for somebody that maybe had a respiratory issue, which is why they were in the hospital. So instead of discharging that patient, they would keep them for additional days until they could try to find a place that would be a better fit for that patient to go to. So it's really important as we talk about length of stay, if this is something that you're doing at your facility, that you look at the seasonal indices and you look at the historical data over time to understand what is normal for that month. Some more utilization measures, we can look at facility capacity. So this is, again, we've got a certificate of need in New York State. So any licensed bed is a bed that is approved by the state, it is available, and it is staffed. So 84% of community hospitals in the US have fewer than 300 beds. The average size of a community hospital is 161 beds, just to give you perspective on size. Average daily census, this is something that is usually discussed on a daily basis at most facilities, is the average number of beds occupied per day. So these are basically the days of care over the total number of days, available bed days available in a facility. This corresponds very much to occupancy rate, which is basically the percent of capacity occupied. We're going to be doing this annually. The basic calculation is if you did this on a daily basis, you could look at your average daily census. So how many patients were admitted or into your facility, and how many available beds do you have? That's a really easy way to calculate it. What we're going to be doing is we're going to basically look at the entire year for your facility. We're going to look at the total number of patient days, and we're going to divide it by the number of available beds multiplied by 365 days a year. It's essentially the same calculation pushed out annually. And this is a really good measure of performance. So you can have, again, two sides to this. If your occupancy rate is too high, we typically try to strive for 85% for our med-surg service category, because you want to leave yourself some buffer to turn that bed over, to make sure that environmental services can come in after the patient is discharged, do a thorough job of cleaning, and make sure it's ready to go for the next patient that's coming up from the emergency department. So we know we have, generally speaking, an 85% target occupancy for a med-surg. If your occupancy rates are higher than that, then that usually means you're going to have boarders. There's going to be bottlenecks in your flow coming up from the emergency department. It's going to create problems for both our providers and for our patients. On the flip side, if your occupancy rate is too low, your facility is not going to be financially viable. It's going to create issues. You're going to have to look at either reducing your overall capacity, and hopefully, ideally, if you're really looking at true population health, how are you looking at other ways that you can make sure that you're creating a healthy population and you're doing the things that you need to do for your patients? So either scenario is not great, but again, it's what we need to be looking at to help us better plan for the future. Long-term factors that affect utilization: first and foremost, the size and nature of the population growth, aging, health status, healthier communities. If we think about those blue zones, communities that are really healthy and live active lifestyles, we're going to see that they have, lower discharge and patient day rates. Advances in medical technology, pharmaceuticals have all worked to reduce over hospitalizations, and we know that we've seen a trend towards moving to outpatient settings and seeing a reduction in hospital admissions. That doesn't mean, though, that there are still not a lot of operational kind of patient flow issues, and that we need to be thinking about, we still need to be thinking about looking at population trends, especially as we know we've got a lot of baby boomers that are growing older and are going to have higher utilization rates. So I kind of alluded to this before, but we're going to be looking strategically at measures of use for our county and for our facility to really understand whether or not we should be adding or reducing beds. But I think it's important that we do this in the context of population health. So not just looking at the financial viability of an acute care setting, but how does this fit into our overall health system strategy? And what are the things that we can be doing to help ensure that our patients are healthy to begin with, and actually try to actively avoid bringing them into our inpatient acute care facilities if we possibly can. The key to doing that, and the key to anybody being interested in doing that, though, is to make sure that we have reimbursement models that are going to support us in that effort. As always, if you have any questions on this content, please don't hesitate to reach out.